A 45-year-old male presents with severe, progressive back pain of several weeks' duration. I'm showing you the anteroposterior and lateral radiographs of the spine. Describe the findings.
Okay, I see it. The radiographs demonstrate narrowing and destruction of the intervertebral disc space at the junction of the 12th thoracic and 1st lumbar vertebrae. There is extensive erosive destruction of the opposing vertebral endplates, accompanied by anterior subluxation and marked anterior angulation of the spine, representing a gibbus deformity. These features are highly characteristic of an active infective spondylodiscitis.
What are the key imaging features that help differentiate tuberculous spondylitis from pyogenic spondylodiscitis or neoplastic disease?
In that case, infective spondylodiscitis is centered at the disc space, showing narrowing of the disc and destruction of both the superior and inferior opposing endplates, whereas neoplastic disease classically spares the intervertebral disc. Tuberculous spondylitis is differentiated from pyogenic infection by a slower, more indolent clinical course and the relative preservation of disc height until late stages of the disease. Tuberculous spondylitis also has a greater propensity for anterior vertebral body destruction, leading to a prominent gibbus deformity, and frequently demonstrates large, well-defined paraspinal or psoas collections with rim enhancement.
I am showing you the sagittal and axial magnetic resonance images of this patient. Describe the findings.
Well, the Sagittal T2-weighted MRI demonstrates high signal intensity within the intervertebral disc, with marrow edema extending throughout the adjacent 12th thoracic and 1st lumbar vertebral bodies, along with partial collapse of the 12th thoracic vertebra. Marrow signal changes are also seen in the 11th thoracic body, indicating multisegmental spread. The Axial T2-weighted MRI demonstrates bilateral, large, hyperintense fluid collections within the psoas muscles, consistent with bilateral psoas abscesses. These findings confirm tuberculous spondylitis or Pott's disease with associated psoas abscesses.
Discuss the clinical significance of psoas tracking and the neurological risks associated with this condition.
Okay. Psoas abscesses result from the direct tracking of tuberculous infection from the vertebral bodies beneath the psoas fascia. Clinically, these collections can track long distances down the iliopsoas muscle to present as groin pain, a palpable thigh mass, or a flexion deformity of the hip. The intraspinal spread of infection or posterior displacement of bone fragments from vertebral collapse can cause spinal canal stenosis and epidural abscess formation. Tuberculous spondylitis carries a high risk of spinal cord compression and neurological deficits, making early detection of epidural extension critical.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these findings with any prior spinal radiographs. I would recommend a chest radiograph or CT scan to search for primary pulmonary tuberculosis, and a full spine MRI to screen for non-contiguous tuberculous skip lesions. I would promptly communicate the presence of vertebral destruction, canal encroachment, and psoas abscesses to the referring medical and orthopedic teams. Finally, I would suggest planning CT-guided aspiration of the psoas abscess for mycobacterial culture and acid-fast bacilli staining to guide anti-tuberculous chemotherapy, and referring for spinal stabilization if instability is present.